very much for staying with us. And my guest for this evening is a medical practitioner and also a public health specialist. Dr. Bernard Okoboy is my guest. Thank you very much for joining us,
yes,
Dr. Okoboy. I believe you're doing very well.
Yes, by His grace, I'm fine.
And you're coping well with the lockdown?
Yep, you know, the lockdown had a few exemptions.
Okay.
People who do essential service, and I happen to belong to one of the categories. So actually, I'm what's the word? I'm observing some level of limited movement. You know, I tell people there's a principle behind every policy. The principle behind a lockdown is to limit or restrict movement to near zero. So absolute lockdown means you don't move, you are at your house. So we can see that we are experiencing some degree of lockdown. And the principle is simple. You limit movement, you restrict the chance of the virus moving to
Talking about limiting movement and restricting the chance of the virus. I mean, I read Michael Osterom, who's an epidemiologist professor, and he says that, well, lockdown is probably not the way to go. He says that, why don't you allow the virus to run its course so you have herd immunity, and then you're good to go. And let's look at the case of New York, for instance. So New York, when they were locking down in March 20th, had about 8,000 cases. Now they have about 52,000 confirmed cases. Yeah. Clearly, even after lockdown, we've seen about 400% increase in the number of cases. Yeah. Doesn't that, suggest to us that the much talked about and, trumpeted lockdown doesn't really help deal with this COVID-19? Well,
as for the efficiency or effectiveness of a lockdown is indisputable. Even the professor who preferred or prefers herd immunity would admit that when you do lockdown, you are able to slow down the rate of transmission. That one is agreed. Now, there are two things you achieve with a lockdown. You can achieve containment or suppression. Containment is where the degree of spread is controlled, such that people are getting it, you get your herd immunity. But because it's controlled, you have the opportunity to take care of those who are severely ill. Suppression is what happened in China. You drive down transmission to zero so that you cut transfer or infection to other people. The risk with suppression is that you take it out, but those who have never been infected, the next time they get infected, they can be seriously ill. What we refer to as another second or a possible outbreak. What we are doing in Ghana is trying to ensure that we limit the transmission to as close as zero as possible, so that we don't get a situation where we are overwhelmed with cases and overwhelmed with serious...
But talking about limiting the transmission, for instance, the president announces on Friday night, effective Monday, there's going to be a lockdown. We saw everything that happened on Saturday and Sunday. Didn't that even defeat the purpose for wanting to lock us down?
All right. So I say that if someone is, let's say, positive and lives in Accra, or is a suspect, or let's say it's not been checked, it's not been tested, came from Europe 3 or 4 weeks ago, and moves from Accra to, let's say, Sunyani. If the fellow goes to Sunyani, the risk is moved from Accra to Sunyani. Once generally people are complying to a limited movement, they reduce the risk as they would have done in, Accra. So if you are in Accra, you have a risk. If you observe a lockdown, you reduce the risk of transmitting to someone else. If you had escaped the 48 hours and gone to Sunyani, once there's limited movement, again the same thing happens. But my brother, everywhere in the world, they don't surprise people with a lockdown, especially when your infrastructure or architecture of society does not allow it. So I'll give you an example.
So are you okay? Yeah, go ahead.
Yeah. So in New York, they can announce a lockdown, and it is effective immediately. The reason is simple. They still allow you to go to their grocery shops. You can go to a grocery. They have data on each citizen, such that they know whichever level you belong to. Those who need to go out before they feed, they can get food to them. It's because we've not gotten to that level yet. So when you want to announce a lockdown, you give a window for people to settle. I gave an example of a doctor who works, let's say, in Sunyani Government Hospital. If he came to Accra to attend a meeting and you want to lock down, it's in your interest to let your people settle in a natural environment. Natural environment, we say, that's where he operates. If you keep him here, you deny yourself of essential services in Sunyani. So as for that one, is allowed, especially for societies whose architecture is not like the first world.
Talking about societies whose architecture, are not like the first world, is an admission that Ghana, per how we are, we're not prepared for the kind of strict lockdown as we've seen in other jurisdictions.
You know, we as a people, we might not have done, let's say, 100%, but we should take some pride in some of the achievements that we chalk in this country. My brother, you have an idea of the traffic in Accra. I move on a daily basis. When you hit the streets today, Accra looks like a ghost town. Largely, I tell people, largely, this is a community, a country that has responded well to this lockdown. I think in the minds of people, they think that when there's a lockdown, you're not even seeing one human being in town. You came from your house to this place.
Yes.
I know people who might have mistaken you for someone who is refusing to stay at home and is trying to be outside.
But I have to show my identification.
No, but the point I'm making is that anyone who counts you as someone loitering around would have made a mistake. So I'm using you as an example for people to know that there are a few people who are providing services that are needed, like you informing the public of what is happening and all that. Look, the policeman you see on the streets, when he's going back, he might not be maybe in his uniform. A nurse might have changed and going home. So there are a few. All we tell people is that if you are not part of the essential workers, if you are not going to do something which is our life and death, like going to get food or gas, your gas is run out, or electricity, because if it's not an essential, it's not a need but a want, defer it.
Okay.
Yeah.
So while you are a member of parliament, you're here, today because you're a medical doctor and also a public health specialist. So let's look at our approach. You've talked about how we've handled it well.
Yeah.
But if I read all the literature, it tells me one thing. And I've been reading Médecins Sans Frontières, for instance. They work in Italy. And one of the first things they talk about is frontline health personnel. Yeah. Because they are the people who are going to ensure that if you and I fall sick, we'll be taken care of. Yeah. What is our situation? Taking good care of them.
You see, even the front line is not only because when you and I fall sick, they'll take care of you. It's because they are the ones who are continuously exposed to people with the case. So it's a high-risk group. Now, they tell us that we should observe social distancing. Imagine a doctor trying to take the sample from a patient 2 meters apart. So the point I'm making is that they have to get very close to patients even to take samples or suspected cases. So their risk is enhanced. And that is why, despite their protection, you still see some recorded cases of health workers either falling sick or some losing their lives. In Ghana here, I can confidently tell you that the PPEs we have in stock now is enough for the cases we have now. The only reason why everybody is calling, and I agree to that call, that increase your numbers, do your PPEs, do a lot of stock, how do you call it, ordering, is that every country prepares according to the modeling. You project potential cases. And it is true. We don't have what it takes to deal with the cases of tomorrow. And that is why you must continuously beef up. And I know the GHS has made some orders. We've ordered close to 37,000 pieces of goggles, clothes, coveralls. They are coming. And mind you, so far we have tested, Noguchi has tested, in fact, in total, in the country, we've done 4,560. Nobody took a sample from any of these people naked, in code. Naked means not protecting themselves. They go with their coveralls. In fact, when you're going to take a sample from a person, you have to wear a coverall. Coverall means you don't wear just a face mask and gloves. You wear the complete one. So the point I'm making is that all our frontline staff, as a country, we've done well to give them what is required. But people have asked, what if we get overwhelmed? Do you have enough? The answer is a definite, we don't have the numbers to deal with potential. And that is why, and forgive me, sometimes the headlines, forgive me because I do politics as well. Some of the headlines that come out give us out or away. Someone will say, oh, Dr. Kobo say, the point I make is that if you make a call for increased numbers, it's justified. Because your modeling is such that you are expecting, you are preparing for the worst. Let me put it that way.
But talking about, I'm
coming. So Ghana, as we speak today, we are sufficiently prepared for the cases we are dealing with. And I'll say the cases of, let's say, in the next week or two. But because we don't know or we don't want to be comfortable, we are still beefing up our numbers with all the orders that the president talked about.
Talking about having enough and talking about needing enough. So you're saying you have to do projections. Just help me understand what the basis of those projections would be. And for you as a health practitioner, when you do the projections, does it look like in the coming weeks we are going to be having a lot more cases than anticipated?
Yes, so the finance minister recently was, maybe later I'll try and get you the exact figures, but the finance minister was in parliament and spoke to the quantities of PPEs that we are ordering, where we talk about gloves, coveralls, talk about face masks and all that in the thousands, tens of thousands, some in the hundreds of thousands. Now, it's absolutely important for us to know that, once again, like I said, the cases that we have today, it's possible that others will trickle in. Now, let's look. We have today's the status quo now. We have 195 cases. Now, that's the prevalence. Prevalence meaning that's the total numbers we've had since COVID started in Ghana. But remember, 5 have passed. 5 have passed on to glory. So if you take out the 5, you talk about 190 cases. Out of this 190, you have about 49 who have been discharged. Yeah, 49 have been discharged. And out of these 49, 38 have tested negative for the COVID. That's why the minister said they had recovered. But in strict terms, you should test negative 2 occasions. And so if you look at the real numbers, we are now dealing with about 130 cases that are active. Active means that are being followed, maybe giving some treatment. In my estimation, conservative estimates, the worst we can do, the worst case picture, would be a doubling of this figure in a week. The worst case scenario. When I say worst, that's the worst. Should things go, 95% of our cases so far are imported. Imported means that they are cases that came from outside. Cases that are occurring in Ghana here are really on the low. I put it on the average. We look at our 10 cases that have what we call active local to local, person to person transmission. It's about 10. If most of your cases are from outside, vertical transmission or imported, and you close your borders, it means the chance that it will be going up steadily like it was doing, it's low. We might have trickling, maybe some 2 cases here, some 3 cases there, from possible local spread. That one, your graph doesn't rise steeply. We are doing 195 now. If it's the local trickling, 1 here, 2 there, we might do, in the next 2 weeks, maybe do around 200. Yes, but the worst case scenario...
That is 200 new cases?
No.
Just
from 195
to 200.
To about 200. That's on the lower side.
Okay.
On the upper side, I've pegged it at an average of 300. Should we go above or below?
Should we go above or below 300?
It will be an average of 300.
That's a departure from the previous one where you anticipated we could get about 600 because of the mandatory quarantine, right?
Yeah, the point is very simple. The measures a state puts in place in public health are normally targeted at preventing community spread. At the individual level, if you are positive for COVID, okay, let me use myself, some people don't like.
Don't worry.
If I'm positive for COVID, the state preparation, whether it's in Switzerland, in Germany or Ghana, usually limits possible transmission from myself to outside contacts. But usually those who are in my immediate environment, like maybe my partner, my wife, my kids, it is only when you test me early that you can guarantee that even there you can keep them aside. But by the time you pick me up, it's possible that they've gotten it already. I tell people, viruses, Apollo in code, the local parlance, Apollo is a virus. The real medical name is viral conjunctivitis. Just look at how Apollo spreads. It is so slippery. So your preparation as a state is to prevent wholesale or community spread. And so with Ghana's best preparation, there is some level of transmission, like I always put it, that you usually might not be able to take away. So that's why I say that Ghana has had 150, at least an average of 150 imported COVID cases.
But let's look at those imported cases that you talk about. Today when the Minister of Health briefed all of us, we'll get to that shortly, but he talked about how 140 contact tracing teams in Accra, and they've been able to identify over 600 persons, and samples have been taken. About 589 samples have been taken. We do not know the results. He's talked about samples having been taken. We do not know the results. And so based on that, wouldn't we be in a hurry to say, for instance, worst case scenario, we could expect just 105 increases. When out of the 589, we don't know the results now.
So as someone who's done epidemiology, done some public health, you are not rigid with your modeling or your estimations. Rigid means if tomorrow we get 300, I only try to understand the basics for that manifestation. And so please don't get me wrong. I have done modest modeling and an extreme one. In my very extreme case, I mentioned, let's say ×2, but I've mentioned on a previous platform before coming here that should Ghana do under 500 cases at our peak, it would have been a good performance. At our peak. Peak means where corona cases cease and then start fizzling out. If we do less than 300, I'll not be surprised, looking at the slow rate of the rise, especially with the local person-to-person spread. It's been very low. In fact, most graphs that have come out have only told us the picture in terms of our wholesale cases. They've not spent time to tell us the graph with the person-to-person. When I say person-to-person, those who gave it to people actively in Ghana here. In fact, for the sake of your viewers, let me say that there are two kinds of new cases. You know, we report cases like the 10 people who came from, was it Burkina Faso?
Yes.
You know, they were captured as new cases in Ghana. Guess it. You see what is happening. 10 cases from Burkina. They were termed new because it was in Ghana that we picked them and added to the global statistics.
Yes.
But in reality, in strict terms, those cases are not the cases I would call new cases. For our statistics, we say new. The real cases that I am concerned about as a health manager or a public health person is those persons in Ghana who came into contact with a positive person and then got infected. Because they give you an idea of how well your systems are doing, whether they are doing well or you need to do some adjustments. And so far, I'm happy to mention that an average of about 10 from what we are seeing are those that have gotten in Ghana. And look, compared to what is happening elsewhere in the world, I mean, we are doing quite very we are doing.
But that's where the issue also is, because you would admit that, you know, yes, comparatively we are doing very well, but it's also because as we speak, yes, we've done the general surveillance, we have the numbers, but we also do not, the samples that we have taken now, we don't have results from those samples.
Yeah.
And so if we had the results, you'd agree that if we had results from those samples, then we could use that as basis to say, okay, based on the outcome of these results, based on the percentages, we can, infer that this could be the spread. Because if you look at all countries, for instance, in Italy, when they started, it was 1 case for 2-3 days, and it goes to 3. But ours was different from that.
You see, if you look at the daily cases that the US, Italy, UK, Germany are recording on a daily, if you check the graphs, their numbers are huge. Maybe, like you said, some will say maybe because they are testing more. But, we have risk levels associated to groups. So let me be candid with you. If we had another batch of 1,000 quarantined people whose samples we are waiting for, I'll be very modest in my, what's the word, in my being positive. I'll be modest. The risk is high with groups that, like the 1,030 we quarantine. See how many were posted.
79.
Yes, that if you that is huge for, it's a significant level for their number, 1,000. If we had another group of 1,000 who had been trapped as in court from another country, I wouldn't be surprised if we get 50 or 100 cases. But as we speak now, the group with the biggest risk is the group that we are done with, which is the how do you call it, the mandatory quarantine people. The contacts you are talking about, see what is happening with the contacts. Over 80 to 90 contacts followed in Legon. What happened?
Negative.
Negative. Confanoche, they received a patient who was ill, who was positive for COVID. They made them go home. All those that have traced, what happened? Negative. I'm not going to say it will be negative for all contacts, but this is the lesson here. It's not every person who is positive for COVID who is contagious.
How?
Being positive is one thing. There's a level of viral load you must have to be positive, for the sample to read positive. There is another level which is way higher, you need to be infectious. So that's why any virologist or doctor will tell you that when you check for presence of a virus, you don't stop there. You check the load in the person. Load means the level of activity.
Is that what we are doing here?
We are not checking the load, but I'm just using that to tell you that the mere fact that you've had a sick student exposed to hundreds of people and they all come negative should tell you that this contact you have, from my estimates, don't be surprised.
Yes,
Maybe less than 2%.
Yes, but if we don't check the viral load here,
yeah,
then it wouldn't be fair to say. I mean, so for us, we don't know at what stage you
are. We are not checking the viral load. Elsewhere, nobody's checking.
Exactly. So yeah, but whatever the case is, if you have it, we should be concerned.
Yeah, that's why. But we also need to explain the clinical picture. There are graphs to show what your body goes through. I mean, it's all part. It's not just the public health will look at the pattern of the disease and the factors, but there's a clinical aspect. The clinical aspect means that if somebody gets infected today, over a period of 2 weeks, they go through a graph. Their immune system rises, peaks, gets a hold on it. That's why their symptoms resolve. Remember, the hundreds of thousands who have recovered from COVID, they recovered on their own immune system. Now, the point we are making is that when they test you and you are positive, the most important thing is that they pick you out. Then they quarantine you to have a fair idea of which point of the curve you are. I just mentioned some few minutes ago that there are some that will even test positive. And it's possible they've gotten infected, they've recovered, and yet you are the first person testing them. A few people in Wuhan who recovered from COVID.
Yes.
Later, when they were followed for 2 weeks, their samples came back and they were positive. The lesson is that even your positive cases, there are positive cases that you get, and really, they've gone through infection and recovery, even as at the time you are picking them.
Great. So let's look at one thing. You talked about, from a public health approach, how it's important to, look at the spread and the patterns and all of that. I see this letter from the Ayawaso West Municipal Assembly. Yes, and I'd like to read a bit of it. So it's signed by Dr. Louise Anati. Yeah. It says that, as a result of this, the directive from the national level has been to conduct a COVID-19 contact tracing of all persons who have come into contact with confirmed COVID-19 positive patients, which was already being done, and conduct compulsory house-to-house testing of every individual residing in Ayawaso West, municipality. Now, before you come in, from your knowledge and expertise, is it right to go about it this way?
No, but with all due respect to yourself and Joy News, I believe when the minister spoke today, and Honorable Minister...
She talks about enhanced testing.
Yes, my brother Kojo Oponkruma, he clarified it that as much as possible, he was very nice in his talk that we should, I will not say disregard, but the policy of the ministry supersedes this one. So what we are doing now is enhanced testing or expanded testing, which is different from mass testing. Mass is when, like they said, let's say compulsorily, you are taking the whole of Lejokuku, my constituency, or the whole of, let's say, Ayawaso. What we are doing now is that previously, most of our tests focused on people who had traveled into the country, like had returned or traveled into Ghana, and people who were symptomatic, as in ill, and have a history of travel. But now we've expanded it or enhanced it to capture every contact that is traced. Every contact means once you've been connected to a positive person, you are added to the list. Because we have some limitation in the capacity. Limitation means that we have the same places. They've now added a place at Kolebu. Formerly it was 2, now we have 3. There are some numbers they can deal with at a time. So some have not yet had their sample taken, but they are part of the list of those who've going to have their sample taken. That is the expanded testing we're talking about. So if you're in Ayawaso and someone is positive in a particular house, and it's a compound house with 4 or 5 people, all of you will be roped in. That's the point we are making. But it's not the case that we are now going to...
Shouldn't you be allowing, the health directorates at the MMDA levels to be taking these decisions as to how they intend to deal with coronavirus, as we have seen in, Akuapem South and North, New Jabing South Municipal Assembly and Accredited Assembly doing? They've actually imposed restrictions on movement of vehicles and all that. Shouldn't you be allowing them to take decisions rather than setting aside and say this should be disregarded and all of that?
Yeah. So forgive me, but I'll do a little bit of medicine here.
Sure.
When you talk about management of a disease, it's a combined term. It refers to both the prevention and the treatment. Mm-hmm. In fact, once you talk about treatment, you also have to bring in diagnosis. So really, when they say, okay, how do you manage, let's say, high blood pressure? They are not referring to only the treatment. They are also referring to how you prevent it. Now, the management of COVID-19 is in 3 parts. the prevention aspect, the diagnosis, and the treatment. So, my brother, the prevention aspect, there are different levels of, activity. State levels, like the policies and interventions His Excellency the President is giving. At the regional levels, there are activities happening to make us comply. At the district level, they can do what you've cited, where you are maybe increasing the level of Veronica buckets that are around. You are making sure that people go through some screening. That is allowed. But diagnosis and treatment, no country in the world leaves it totally to the, municipal level. There's some level of coordination, and the reason is simple. COVID-19 is a PHEIC, Public Health Emergency of International Concern. Once any health condition falls in that category, the fight must be national, as in the country. There are some things you keep hold of and monitor. We will not get to the place where Lejokuku Municipal Directorate will be deciding who to test, whose samples to take. No, there must be some policy direction from the top. There's a national coordination. Even in the US, where it's a federal country, you remember that they have some level of autonomy in what they are doing, but they still are working with some directives from the top.
Yes, but of course, I mean, with the Ghana system also, you give people some form of autonomy.
Yes, I agree.
So if you give them some form of autonomy, you should be allowing them to take some of these decisions. Are you either suggesting, for instance, that the decision taken by the Krapim North and South, municipal assemblies, together with the New Jabbing South Municipal Assembly, no, not about that one, about the fact that they've actually requested that all persons who moved from Accra to hotels within these districts, all the guest houses and hotel owners should be providing their details for contact tracing. They have actually stated that. So, and it is the district assembly that is championing this. They have decided that they are going to, all pubs should close down. They're saying that they will be monitoring taxis and trotros. They should practice social distancing. These are district assemblies putting in place proactive measures.
All right. Remember that they appear to be acting independently, but you'll be surprised that it's very likely, I suspect, they have the tacit either support or instruction or directive from the top, and I'll explain. Most of the places you've cited are hospitality areas, so that since 3rd March, the President said we should go back to 3rd March, get a manifest of all those who traveled. The Information Minister, my brother Kojo Oppong-Nkrumah, mentioned that we've had about 30,000 between the time 3rd March to the time we did the mandatory quarantine. Most of these people might be travelers who will visit some of these places. So again, they really fit into the expanded testing or enhanced testing, where you are looking at people who might have traveled from Accra with a travel history of having gone to Europe.
Their letter says, following the lockdown in Accra, the announcement of a lockdown and movement of people from Accra to these areas, they, as DCEs or MCEs of these assemblies, have decided to do
maybe.
And I am asking, since you say it comes, it should come from, we should have a national approach. These are MCs and DCEs saying this is what we want to do.
I see them as giving directives that seem to discourage people from trying to break from trying to disobey the directives we've received to stay in Accra, especially for those of us in the Gama area. These directives are meant to enhance or support what the President put in place. But really, you should know that if anybody is trying to break these boundaries, it's the police and things that must help. I will not discount or downplay their efforts, but whatever happens, if they should do testing of all these groups, they will still need the approval and support of the ministry. Once again, the Public Health Emergency of International Concern, you don't take your own policies. Policy must be at the top. You receive it, and then you are part of the process. That's how it is.
So in this case, our decentralization process would have to,
I've told
defer everything.
No. I've told you, management of a condition is in two parts. The prevention part, which can vary based on the level of based on the area. In fact, when you go to some communities, the overall municipality preparation might be better than a municipality preparation. Let's say Lejokuku's preparation might be better than a municipality in, let's say, Eastern region or Volta region. You see the differences. So that's where the independence or the level of autonomy comes in. But when it comes to diagnosis, what criteria, you cannot say that I've used my own criteria in Lejokuku, 2 people have recovered. You see, this condition, even we as a country, we are using protocols. That's why the last time we mentioned that some people had recovered and later they were pulled back. We are supposed to satisfy protocols that are worldwide.
Great.
Yes.
We'll come to the protocol. But since you've mentioned some people recovering, I had a health minister say someone, tested negative, they tested again, and the person tested positive. So the person is on medication now. Under what circumstances do these things happen? I mean, particularly when the person was still undergoing, isolation and then had to go through this.
Well, I think I've listened to people who say that the figures from the health minister and the one posted on the Ghana Health Service official page appears to, there's some discrepancy. But really, I had a breakdown. I was just trying to get it for you. Okay, so.
But I listened to him carefully.
Yeah.
Yes.
So what happened was that the minister mentioned that recovered cases, we've had 38 recovered cases. Now, if you look at the Ghana Health Service, their website, they say 49 have been discharged.
Yes.
Now, out of these 49, 38 tested negative. They were previously positive. They tested negative. But the minister, they've been allowed to go home and still be under some quarantine. Minister classified them as what? Recovered. But the Ghana Health Service haven't put recovered there. The reason is very simple. If you test negative for the first time, on the face of it, you are negative. But the WHO criteria is that you have to test negative 2 consecutive terms. So they are yet to do the second one. And so it's about fitting a strict criteria. They are negative. They are, in fact, to be negative, to have been declared recovered, your symptoms must resolve. Resolve means that you were coughing, you had a fever, all are gone. And then you've tested negative twice. That's a strict criteria for recovery. Anytime you see recovered on any global map, they went through these strict criteria. In Ghana, the 38 the minister referred to have tested negative the first time. But Ghana Health Service, it is their records that will be fed into the national statistics. So they strictly want to get a second test before they classify them as recovered.
Yeah, but that person who tested, so 31, yes, that's from the mandatory quarantine, and another 18, so it's like 49, another 18 from the general surveillance have also, under home management, if I can put it that way. But for that person who tested negative and later tested positive, this is from a clinical point of view. I want your explanation on that. What could get one who tests negative and then is still in isolation, still being taken care of by medical practitioners, then test positive on a second test?
So the first one, which I would guess is what we refer to as a false negative test. So
what does that mean?
Yeah, so when he had a negative test the first time, it's possible that it should have been positive. When you get your lab results, sometimes for some reason the result you get might not be what it is. So sometimes they can ask for a confirmation or a confirmatory result. It can be different. So the first person, we can assume that the first time he tested negative, he should have tested positive. What it means that the negative he had was a false negative. That's the term we use. So if you should have had a positive test for a particular test, and then they gave you negative, we say it's a false negative.
Okay.
Yes. So this guy, I'm just giving the scenarios. If he tested negative and positive the second time, and really is positive, what it means is that his first negative result was a false negative.
Okay.
It's also possible that, yes, the negative he had the first time is correct. But how can it be positive again? They've done research on some people who recovered in Wuhan, in China. They followed them for 2 weeks. I read an article. Some of them, after having been negative 2 consecutive times and having been classified recovered, tested, and this time, after being followed for 2 weeks, they tested positive, and they gave reasons. One, and I've mentioned it here, the viral load you need to test positive is different from what you need to be sick. So let's say you need 10 copies of the virus in your blood to be positive, but you need 1,000 to be ill. So the point they're making is that at the time you recovered, your immunity would have brought the viral activity way down to, let's say, 8, so you are negative. The viral activity can rise again to 10 where you test positive. But because of your immunity that you've gained, 2 things. One, you are not contagious. Contagious means your activity is not high to infect others. And then 2, you will not be clinically ill. So you have what they refer to as subclinical infection. It is there, but you are well. You have immunity as well.
We'll come back to this very issue because we need some more clarifications on all of this. My guest is Dr. Bernard Okoboy, who is a medical practitioner and also a public health specialist. This is Upfront, and I'm Winston Amwa. Stay with us. We'll be right back after the break. All right, so welcome back from that short break, and thank you very much for staying with us. This is Upfront on Joy News. I'm Winston Amwa, and our guest this evening is Dr. Bernard Okoboy. We're talking about, dealing with COVID-19 from a public health approach, more or less. But let's look at one important thing. You've talked about the fact that there could be a false negative. In that case, could it be that some of the, results could turn out not to be as it is, if this could be the case?
Well, those who do biomedical science, those who are into laboratory medicine, will tell you that there's always some, we call it percentage or margin of error in laboratory tests. That one is global. So even the UK, the US, the bottom line is that you know your results have some degree of reliability. Even if it's 98%, it means you admit there is a 2%. And so, scientists are humble people, like I put it. You don't want to behave like you are 100% absolute about your figures. So in trying to explain that phenomenon where someone was negative and later tested positive, those are some of the things. It doesn't mean that because of that your figures cannot be trusted. In the US, that percentage that exists here in terms of marginal error exists in the US, exists in
so
UK.
There's a possibility that
everywhere
some of the results could be the opposite.
Yeah, I don't want us to necessarily spend time on that.
No, I'm just asking that there's a possibility.
I would have spent time if it was unique to COVID-19 in testing for diabetes, in testing for hypertension, in testing for every condition.
So there's that possibility.
Absolutely, I've told you. Yeah.
Great. Let's look at Ghana's situation. One thing that has come up here is we realized that in the Western world, there seem to have been a lot of cases. In Africa, the country with the highest case is South Africa, about 1,300.
Yeah.
You've talked about the activity of the virus as well. What is it that is making us not have so many cases from a public health point of view? What are we doing right?
Yeah. So like they say, epidemiology looks at the distribution of a disease in a community and the factors accounting for the distribution. Some might be known immediately. Known means that they are scientifically proven. Some might be guesses or assumptions, or like they will say in science, hypotheses. Well, I have listened to people who speak to what we refer to as the heat hypothesis, meaning where viruses or germs or bacteria behave in particular ways based on the temperature. Now, I also know that if you have a virus that prefers cold regions, when the temperature is cold, the activity can be high, meaning their chance of spreading is faster, and their disease presentation, as in how active they are in the person to cause disease, also is high. So you see that people can present very ill when you take the numbers that you get for positive cases. In Ghana, we have a situation where out of the 138 cases that we are dealing with now, when I say dealing, they are the cases we are treating.
Okay.
Not even one is in a severe condition. In fact, we have some 3 or 4 that are on admission and being monitored.
But those who died, they were in severe conditions resulting in their death.
But when you are counting, we are dealing with current statistics. Those who are passed, have exited, are 5. Yes, some got into severe condition. But again, even that, you have to look at it well. Most of those who died have serious underlying medical conditions, what we refer to as comorbidities. Some had kidney problems with heart problems. Some have a lot of issues. And so I admit that they were positive at the time they died, but they had a very, genuine, significant medical problems.
Okay, so let me just get back to this bit about, the false negative, just by way of clarification. So when it happens like that, I know you would probably go for a second test. You go for another opinion. When it comes to the testing of COVID-19, within Ghana, do we have second opinion? I mean, I know we have only 3 centers now, including Kolebu now, which you are board chairman. When it happens like that, where do I take it to? Can I personally request for another test?
You know, if you go, I like to use, I'll mention the US, I'll mention the UK. They will not test one person twice. Although they know that in biomedical science, there is this 1% margin or 0.5% error. When I say 1 or 0.5, as in it's not 100%. So that you are not surprised when one particular one is retested somewhere, you get something else. But largely, you trust what you get because the efficiency is high. Now, nobody will say I'm testing one person twice because that margin is there. And then secondly, forgive me, but when you even have numbers that are in the queue, remember in Germany there are numbers in the queue. When I say numbers in the queue, there is some part of the population you've not tested yet. So if you had a luxury, it's better to test the whole population and finish than to be testing someone who's gone through already.
Isn't that problematic? Because it could also put some of us at risk. We might be taking treatment for what we do not have, and psychologically might be affected for what we do not have.
No, but like I've told you, it's science. When you go and see your doctor, take COVID-19 out. All these things I've told you, they are applied to all conditions.
Okay.
So
now, I know the Kolebu Teaching Hospital is building an isolation center. What stage is it?
Well, they are on. We hope to, in about 4 to 6 weeks, be able to complete it. It's these structures that you can raise in a short time. Yes.
And at what point in time would you call for a total lockdown?
Well, if you look at how our graph is now, we have prevalence, as in total cases recorded, is about 195. When you take away those who have been discharged, those who have recovered, those who are dead, we actually do about 138 cases. So the graph is not really at 195, it's 138. As we go along, with the way we see our trickling in, those who recover are likely to be more than those who are coming out. So with time, there might not be the need for a hardening of the lockdown, as in tightening it. If we are lucky, we might rather be thinking of coming out of it.
Well, Bernard Okoboy, thank you very much for joining us this evening. So that's it from us this evening on Joy News. My name is Winston. Up next, let's drive. Have a lovely day.